Oh, okay. Hello, everyone. I feel honored to have the opportunity to speak in front of so many distinguished doctors. Today, I'm here to share a real case titled large B-cell lymphoma with acute myelitis as an initial symptom. I'm He Yufan, a postgraduate student of Dr. Zhang Xiaodong. Now I will present this case on behalf of my supervisor. Dr. Zhang Xiaodong is an associate professor and master's supervisor in the Department of Neurology and Sichuan Medical College. We hope that by sharing this case, we can provide a reference for clinical research and practice and enhance clinicians' awareness of such disease. Firstly, we believe that it is extremely rare for mature B-cell lymphoma to present with acute myelitis as the initial symptom, and it is prone to being misdiagnosed as a neurological disease. Early diagnosis and treatment are crucial for improving the prognosis, but in clinical practice, treatment is often delayed due to a delayed diagnosis. Secondly, the diagnosis and the treatment pose challenging. The clinical manifestation of this disease, like specificity and the imaging examination, are prone to being confused with other spinal cord diseases. Pathological diagnosis require multidisciplinary collaboration, and the diagnostic process is complex and time-consuming. Treatment also requires comprehensive consideration, and it is difficult to implement individualized treatment. I will report from the following 4 aspects. Lymphoma is a malignant tumor originating from the lymphohematopoietic system, which is mainly divided into Hodgkin lymphoma and non-Hodgkin lymphoma. Mature B-cell lymphoma is a type of non-Hodgkin lymphoma, originating from mature B lymphocytes and having a high degree of heterogeneity. Non-Hodgkin lymphoma has a variety of symptoms, such as painless lymph nodes enlargement, fever, light weight, and weight loss. Lymphoma can involve the whole body, often affects lymph nodes, the spleen, the bone marrow, etc., leading to damage the lymphatic system and other tissue and organs, which seriously affects the health of patients. Acute myelitis is a central nervous system disease characterized mainly by spinal cord inflammation, which often lead to limbo paralysis and sensory disorders. The causes are complex and may be related to various factors such as viral infection, autoimmune reaction, vaccination, and so on. Next, I will introduce the situation of this case. The patient is a 7-year-old male. More than ago, he suffered from tuberculosis of the lung and received regular anti-tuberculosis treatment for 1 year. There are no other special medical histories. The patient was admitted to the hospital due to numbness and weakness in both lower limbs, difficulty in urination, and recurrent fever. During the first onset, the patient developed a progressive weakness and pain in both lower extremity without obvious incentives. The pain gradually intensified, and then the patient experienced instability in standing and problem with urination. After being examined in a community hospital, the patient was diagnosed with acute myelitis after receiving hormone shock therapy. The patient was discharged from the hospital while using crutches. The second onset occurred when the patient developed numbness and weakness in both lower limbs after catching a cold, accompanied by disorders of defecation and urination function and a low fever, with the highest body temperature reaching 38 degrees Celsius. Local hospital administered another round of hormone shock therapy. After the treatment, only the patient's body temperature was brought under control, while the other symptoms remained unchanged. Therefore, the patient was readmitted to our hospital. In the neurology, they were finding a decreased muscle strength in the lower limbs and abnormal myelitis in sensory and motor sensation. The general examination results were normal, and meanwhile, there was no lymph node enlargement. In the cerebral spinal fluid examination, abnormal pressure, increased protein, etc. were observed. The blood routine tests indicated and increase in infection indicators, and the examination of other specific antibodies were all negative. The CT scan showed change of chronic lesion. Importantly, we observed abnormal physiform signal and cirrhosis during the enhanced magnetic resonance imaging scan of the cirrhosis vertebrae. More important, we detect a space-occupying lesion in the lower segment of the right ureter on the enhanced abdominal CT scan, and it has affected the urinary system. After the patient was admitted to the hospital, we administered prednisone treatment, but the efficacy was poor. 8 days after admission, the patient had a fever again, with the highest body temperature reaching 40.3 degrees Celsius. We provide anti-infective treatment. Meanwhile, we recommend that the patient undergo a CT-guided percutaneous biopsy. After 1 month, the CT comparison revealed that the space-occupying lesion below the right kidney had enlarged. Meanwhile, the pathological biopsy suggested that there was a mature B-cell malignant tumor in the tissue obtained from the right kidney puncture. Unfortunately, the patient's family member refused further examination and treatment. The patient passed away 9 months after the secondary central nervous system lymphoma usually has a subacute onset. Due to the lack of specificity of clinical symptom, pathological biopsy is the gold standard for diagnosis. However, in the real world, the number of confirmed cases relying on pathological biopsy is rather small, and the diagnosis of SCN-ASL is extremely difficult. Different studies have found that it takes several months from the onset of symptom to the diagnosis, and in the longest case, it can even reach 18 months. Moreover, lymphoma with acute myelitis and the initial symptom is even rarer, making the diagnosis even more challenging. In this case, it took 7 months from the onset of symptom to the diagnosis. Throughout the entire course of the disease, the patient only present with spinal cord symptom, recurrent fever, and space-occupying lesion in the right kidney. There were no change in body weight, splenomegaly, cytopenia, or other common signs of lymphoma, which complicated the diagnosis. Due to the anti-inflammatory effect of the hormone therapy, the patient's spinal cord lesion became smaller than before, and the symptoms were alleviated. Although the lymphoma with a spinal cord is extremely rare in clinic, when the common cause, such as acute myelitis, inflammatory demyelination, and paraneoplastic myelopathy are not clearly diagnosed, and the treatment and the treatment effect is poor. Clinicians must broaden their thinking and consider the possibility of lymphoma, particularly in patients with recurrent fever of unknown origin. In this case, the patient survived for 9 months from the onset of the disease until death. We believe that if the diagnosis had been made clearly and the intervention had been carried out earlier, perhaps additional treatment would have prolonged the patient's survival period and alleviated the symptom. That's all for my report. Thank you.